Hi there, my name is Jenny Jenkins Sakine, and this is my presentation on shoulder dystocias. What is shoulder dystocia? And the audience is for midwifery clients, but I think that it would be relevant for any birth workers who are not familiar with the topic. So, first up, what exactly is a shoulder dystocia? A shoulder dystocia, in more medical terms, is the failure of the shoulders to spontaneously negotiate the pelvis after delivery of the fetal head. But more simply, it is when the shoulder of a baby who's being born vaginally gets its shoulder stuck behind the parent's pelvis. So you can see here in this picture that the pubic bone is catching that baby's shoulder bone. This isn't a skin or tissue problem. A lot of people think that maybe you could do an episiotomy and that would release a shoulder dystocia, but unfortunately, this is not the case. This is a bone on bone problem. Like in that previous picture, we saw where the baby's shoulder bone was caught up against the pubic bone. Cutting skin or tissue wouldn't solve that issue. So, what causes shoulder dystocia? While there are a few suspected risk factors like gestational diabetes, macrosomia or bigger babies, and using an epidural, there's no predictable hard set of risk factors, which kind of makes this a tricky situation, which we'll get to later on. But there's no concrete risk factors for shoulder dystocia. Shoulder dystocias can cause brachial plexus nerve damage, postpartum hemorrhage, hypoxia, and maternal damage to the bladder, anal sphincter, and rectum. You can imagine if you picture that baby with its shoulder caught behind the pubic bone, if someone's pulling on that baby, that could cause that brachial plexus nerve damage, which is that nerve in the baby's shoulder and neck area that would get pulled on. It can also cause that hemorrhage from being, taking a little while, um, and yeah, it's pretty bad damage to that bladder, anal sphincter, and rectum if not handled appropriately. Here we have a cute little baby born at home in the picture. So, can shoulder dystocia be prevented? The tricky part is, we don't know exactly what the risk factors are. So, how can we prevent something that we don't know what could predict it? And there is no way to accurately predict a shoulder dystocia. And here you can see from this quote from the American College of Obstetricians and Gynecologists, the shoulder dystocia is an unpredictable, unpreventable obstetric emergency. Studies have shown that pre-pregnancy, antepartum, and intrapartum risk factors have extremely poor predictive value for shoulder dystocia. The best thing to do to help shoulder dystocia is proper training. Proper training goes a long way because shoulder dystocia is unpredictable and happens unexpectedly. Care providers and members of the birth team need to be trained and prepared to relieve shoulder dystocia quickly without causing harm to the parent or baby. So the whole team should be trained and ready to go for a shoulder dystocia to happen at any birth because a shoulder dystocia can happen at any birth with a tiny baby, big baby, uh, any of these things, a parent that has gestational diabetes, a parent that does not. Just there's so many different ways that we could look for risk. And then when we're not looking for those risks and think, oh, this is a small baby, it won't get caught, that's the time that the baby could be caught. And we need to make sure we have a birth team who's ready to go. So, are cesarean sections an appropriate preventative? So, if we see a baby who's macrosomia and we're like, oh, this is a big baby, they could get caught behind their parent's pubic bone and causes damage and etc. Well, first off, macrosomia isn't always going to cause shoulder dystocia, and it would take nearly 3,700 unnecessary cesareans to prevent one case of permanent injury due to shoulder dystocia in a baby that's suspected of weighing 9 pounds, 15 ounces or greater. And, cesarean surgery comes with its own risks. There's a lot of different things that can happen after cesarean surgery when you're asking for the parent to have an increased recovery time on top of everything else that could possibly go wrong in that recovery time. Shoulder dystocia is the fifth most common reason for a cesarean section, making up 9% of all cesareans. So, what about inducing? Can we induce someone's labor early as an appropriate preventative, to help baby not be too big or to stop a shoulder dystocia? Not really. Inducing to prevent shoulder dystocia when you can't accurately predict who will even have a shoulder dystocia is not evidence based. The induction of labor has several of its own risks for parents, and inducing for suspected macrosomia in order to prevent dystocia is the fourth most common reason for induction, making up 16% of all inductions, which is wild because it's not evidence based practice. And if you're a birth worker, you've probably had a client previously who has been told the baby's going to be too big and won't fit. Um, and I've seen some pretty big babies coming through, and some pretty little ones have a hard time. So, once again, this is an evidence based practice here to induce to prevent shoulder dystocia. So, how is a shoulder dystocia solved? If you can't use cesarean section and you can't use induction, what can you do to prevent a parent and their baby from suffering any consequences of shoulder dystocia? One thing that a birth team can do is the McRoberts maneuver. And this is when trained birth team personnel aid in pushing the parent's legs back to the parent's head. So this is you're gonna their knees will be towards their head, and the birth team is pushing their feet backwards towards them. This hyperflexes the parent's hips and knees and creates more space for the baby to release their shoulders. So you're widening that birth canal space so the baby can get through. And then there's a sacral promontory or back of the pelvis that is flattened to have more room. And then finally, pressure is applied to that fetal shoulder, and it pushes that shoulder downward below the pubic bone, so baby can navigate underneath that pubic bone. This McRoberts maneuver alone is believed to relieve more than 40% of all shoulder dystocia, and when combined with suprapubic pressure, resolves more than 50% of shoulder dystocias. So just widening that birth canal and pushing baby's shoulder underneath that pubic bone can release that shoulder dystocia, and they don't have to have a cesarean or an unnecessary induction. The biggest thing you can do to prevent or deal with shoulder dystocia is to be properly trained and ready at all times at every birth for a shoulder dystocia. One of the most important things that can be done, um, yeah, right here, is having a trained birth team that's prepared to release shoulder at every single birth they attend. So no matter what the risk factors are, you need to be ready. A baby could come with the gestational diabetes parent, which we probably wouldn't be dealing with as midwives, or a non-gestational diabetes client. You could suspect a huge baby, and the baby comes out just fine, and then have a little 6-pounder who gives you shoulder dystocia issues. You just have to be trained and ready to go. And here's a picture of me and my preceptor and a fellow birth worker, a fellow student. And here are my references. Thankfully, there's some pretty fantastic contributors to this information. So, thank you so much for watching my presentation. I hope it was informative, and have a fantastic day.